Dr. Swarnapriya, Associate Professor from Sree Balaji Dental College. I am an oral and maxillofacial surgeon. I am here to give a small presentation about ameloblastoma. Introduction. Ameloblastoma is known as a benign odontogenic tumor with locally aggressive behavior that represents almost 10% of all mandible and maxillary tumors. Ameloblastoma is usually defined as a true neoplasm of enamel organ type tissue which does not undergo differentiation to the point of enamel formation. Robinson aptly described this tumor as usually unicentric, non-functional, intermittent in growth, anatomically benign and clinically persistent. History. Here the term ameloblastoma was first coined by Churchill in 1934 to replace the term adamantinoma coined by Malleus in 1885, since the term implies hard tissue formation and no such material. Pathogenesis. Here the cell rest of enamel organ, either remnants of the dental ramina or remnants of Hertwig's root sheath, the cell rest of Malleus. Epithelium of odontogenic cyst, particularly the dentigerous cyst and odontomas. Basal cells of the surface epithelium of the jaws and heteropic epithelium in other parts of the body, especially the pituitary gland. The clinical features. Here the male into female ratio is about 1:1, around 33 to 39 years of age and most commonly between 20 to 60 years of age. Mostly 10% of cases are reported in children less than 10 years of age. It is more common incidence in Asians and in Africans. Mandible constitutes about 80%, more occurrences in molar to angular ramus areas. Diagnosis is mostly done by using OPG, CT, biopsy and a general physical examination. So, classification. Ameloblastoma, according to WHO, it is classified as ameloblastoma extraosseous and metastasizing ameloblastoma. Ameloblastoma clinical types, it is of solid or multicystic type, unicystic type, extraosseous or peripheral type, and according to histological variants it is classified into follicular, plexiform, acanthomatous, granular cell, basal cell and desmoplastic. Classification is mainly into central or peripheral. Central type arises within the jaw. Peripheral type presents as a slow growing mass with a sessile or pedunculated base arising in the gingiva without involvement of the underlying bone. Central ameloblastomas are classified as multicystic or solid or unicystic. Multicystic or solid ameloblastomas tend to be more aggressive and have a higher likelihood of recurrence after surgery when compared with unicystic and peripheral ameloblastomas. Richard and colleagues reported that 92% of ameloblastomas were multicystic, 6% were unicystic and 2% were peripheral. Malignant ameloblastomas may be classified as metastasizing ameloblastoma, the more aggressive ameloblastic carcinoma. The symptoms include facial asymmetry, expansile swelling of the jaws, pain, paresthesia, malocclusion, displacement and loose tooth, ill-fitting dentures, dysphagia and difficulty in speech. Histologically, it is classified into follicular ameloblastoma, plexiform ameloblastoma, acanthomatous type, basal cell type, granular type, desmoplastic type, unicystic ameloblastoma into luminal, intraluminal and mural types. These are the histological representation of the ameloblastomas of different types, mostly the follicular, plexiform, granular cell, acanthomatous, basal cell, desmoplastic, unicystic ameloblastoma. So, here Hartmann has reported granular type to be more aggressive and of high recurrence. Follicular is the most common type. Some cases report with tiny cyst along with this follicular type. Richard reported the resemblance of tumor cells to ameloblast in this type. In the plexiform type, it has irregularly arranged stellate reticulum like cells. In acanthomatous type, the stellate reticulum like cells undergo squamous metaplasia. Basal type has resemblance to BCC of skin. Desmoplastic variant is found in a dense collagen stroma that may appear hyalinized and hypocellular. Pituitary ameloblastoma, it is a neoplasm of CNS originating from unobliterated portions of craniopharyngeal duct which is derived from the Rathke's pouch. Often destroys the pituitary gland. Microscopic features do not resemble ameloblastoma. Extent of treatment should be decided on the type of tumor, that is unicystic or multicystic, and not on the grounds of histologic classification. There are different treatment options, mostly conservative surgery like enucleation and curettage of bone combined with marsupialization, cryotherapy and application of carnoid solution. Radical surgery like resection can be done, and radiotherapy for tumors that are not amenable for resection and for recurrence. So, there are the general principles are the treatment must be guided by consideration of the behavior and the potential of the tumor. The goal of the treatment is the total removal of the tumor by whatever surgical procedure or combination of procedures is necessary. Less than complete excision is equivalent to planned recurrence. The first procedure should be planned to be definitive and offer the best opportunity for cure. Why curettage is not enough? So, here the curettage and enucleation of ameloblastoma either separately or in combination have resulted in recurrence. So, curettage can disperse the tumor into uninvolved areas and make necessary subsequent procedures more tissue destructive. So, it is difficult to follow healing by radiographic examination of a lesion that has been treated by curettage, because recurrence may appear radiographically similar to the formation of bone. So, surgical interventions such as partial maxillectomy with prosthesis, marginal mandibulectomy or segmental mandibulectomy and osteomyocutaneous free flap reconstruction may be needed, depending on the location and the extent of the lesion. Patients who are reconstructed with an osteomyocutaneous free flap may be considered for osteointegrated dental implants. The dose fractionation schedules are similar to those used for carcinomas and range from 66 days in 33 once daily fractions, 5 fractions per week for microscopic residual disease to 70 days in 35 once daily fractions for a treatment duration of 7 weeks. The report of Kim, supported by the study of serial biopsy on the treatment of ameloblastoma by radiation, indicated that the neoplasm is highly radioresistant and radiotherapy is not warranted. But malignant metastasizing ameloblastomas have to be treated with radiotherapy followed by radical surgeries. Maxillary ameloblastomas are found to recur very often because the tumor invasion is facilitated by the higher cancellous bone percentage. Proton beam irradiation would be advantageous for patients with maxillary ameloblastomas extending to the skull base to treat the tumor adequately and reduce the dose to CNS and visual apparatus. According to Huffman and Thatcher, treatment should be based on the clinical features of the tumor, including slow growth, tendency to not invade soft tissues and the lack of wide dissemination. They therefore recommended complete removal of the tumor with preservation of the inferior border of the mandible whenever possible. The linear margin for resection is believed that 3 cm is the most acceptable linear margin, while recommended at least 1.5 cm and preferably 2 cm bony margins for cure of this neoplasm. A review of 82 ameloblastoma resections shows that this tumor extends with a range of 2 to 8 mm and a mean of 4.0 mm histologically beyond its radiographic demarcation on specimen. When the specimen radiograph indicates that less than acceptable 1 cm bony linear margin has been obtained, the surgeon may wish to submit frozen sections of the medullary portion of the stump of the bone in the tissue bed rather than resecting the additional bone. So, the comprehensive treatment includes the protocol of ameloblastomas. In case of small lesions, excisional biopsy has to be done followed by a bone curettage. In case of unicystic or a solid multicystic ameloblastoma, marsupialization can be done with strict follow-up in case of effective cases, but mostly enucleation with curettage is followed in recent times. If in case of ineffective, it might proceed to a marginal or segmental resection. So, in case of solid lesions with clear boundaries, enucleation with bone curettage has to be done, and without clear boundaries, a marginal or segmental resection has to be done. Conclusion: studies have shown that cases treated with resection of 1 to 1.5 mm linear bone margins have better prognosis. Curettage of the bone is discouraged as it may lead to implantation of tumor foci into the bone. Adjunctive treatment of the bone tumor bed by chemical fixation with cornoid solution is of theoretical but unproven value, and cryosurgery gives inconstant benefit as well as risk of sequestration or pathologic fracture. Hope you all understood about ameloblastoma. Meet you in another interesting session.